Yes. Hello. Good morning, everyone. At the outset, let me thank Dr. Deepak Kaldipur sir and Dr. Vishwas for giving me this opportunity. And my sincere thanks to Micro People for bringing this MedTrain conference. And the topic of the day is Botox in migraine prophylaxis. I know this is like ENT crowd, and people might be wondering why Botox and why particularly migraine. Most of us are migraine sufferers. Either we diagnose or we are not yet diagnosed. Most of us have migraine. The problem here is migraine always need not be present with headache. The confusion is migraine is always not headache. Migraine can be in various forms. Suppose if you take vestibular migraine, the only presentation can be vertigo. There need not be any headache. You can take abdominal migraine where the only presentation can be severe abdominal pain, no headache. But in most classical cases of migraine, you'll be having headache. So let's go through what is migraine very briefly. What are the treatment options that are available? And why is Botox important in migraine? How to do it? What are the complications? And also in the last few minutes, I will also enumerate the other uses of Botox in ENT and head and neck surgery. See, migraine is the second most common disability worldwide. It is the second most common disability in the worldwide. Most common disability in young women, particularly between 16 to 49 years of age. So 15 to 17% of the total women population in the world are migraineurs and 6% of the men are migraineurs. See the demographic data. What a huge load of disease burden. So it can be characterized by many versatile symptoms. It can present with a pulsatile unilateral headache, nausea, vomiting, vertigo, and as the gathered population here are like of ENT, I want to specifically show these 3 points. Vertigo in a migrainer can be vestibular migraine. Or if you are having a patient with isolated unilateral tinnitus, where your autoacoustic emissions or inner ear function is absolutely normal, think about migraine in your differential diagnosis. And also temporary unilateral sudden sensory neural hearing loss. Keep migraine as your differential diagnosis. So what could be the triggers of migraine? See, food can be a trigger of the migraine. That is lack of food. Fastings can trigger migraine. Chocolate, citrus fruit, fatty or fried foods, food colorings, excessive tea, coffee intake, beverages, alcohol, and dairy products. So these can trigger migraine. So any weather changes, fasting or exhaustion, changes in sleep pattern, emotional stress. That is, these are the lifestyle patterns which are the triggers of the migraine. And polyglutamine repeats and frame shift variations. These could be the genetic reasons. And estrogen level, high insulin level, free iron deposition, monosodium glutamate, which you find in most of the street foods. Metabolic derangements, changes in the ovarian hormone secretion, mitochondrial enzyme dysfunction, and concentration of heavy metal and level of nitric oxide. These are the other physiological and biochemical factors that act as triggers for your migraine. See, basically, brain needs to be in a state of homeostasis. Whenever that homeostasis is any of these reasons, the brain manifests it as in form of migraine. So, if the symptoms are due to lack of sleep, you sleep well, your migraine will go. If the symptoms are because of improper intake of food, particularly most of us, we have our lunch around 4 o'clock or 5 o'clock in the noon. Obviously, we tend to become migrainer. Have your food, have your lunch at 1 o'clock or 1:30, take a small break. Yes, your headache symptoms will improve a lot without using any medication. So you need to look into the genetic factors because there are certain disorders like familial hemiplegic migraine, episodic ataxia, spinocerebellar ataxias, excuse me, which are which have a already pre-described genetic derivations. Now, briefly about the pathophysiology of migraine. See, whenever the homeostasis of the brain is being disturbed, the multiple afferents carrying the parasympathetic signals from these areas, that is the lateral hypothalamus, the bed nucleus of stria terminalis, paraventricular hypothalamic nucleus, and piriform cortex, they all send signals to the superior salivatory nucleus. Superior salivatory nucleus. This parasympathetic triggering of superior salivatory nucleus through pterygopalatine ganglion goes to the meninges, causing vasodilatation. It causes vasodilatation. The mediators for that is the CGRP. CGRP. The mediator here for the vasodilation is the CGRP. That's why most of the recent or latest migraine treatments are focused on CGRP, targeting the CGRP, that is CGRP antagonists. Right. So after that, those signals are being carried through the trigeminal ganglion because the afferents from the dura mater and the dural vascular supply is through the trigeminal nerve. Those reaches the trigeminal ganglion and from there to the trigeminocervical complex. From the trigeminal cervical complex, it reaches the trigeminovascular complex. From there again, it is related to the hypothalamus and brainstem, culminating in the thalamus. So that will manifest as a headache. So if the symptoms from the brainstem dominates, probably you can get a tinnitus, you can get a sudden sensory neural hearing loss or vertigo also. So the triggering of pain via trigeminal-vascular complex. As we have seen, the fibers, afferent fibers from the dura go and terminate in the trigeminal ganglion. And from there to the trigeminocervical complex. From there again, it ascends to the superior salivatory nucleus and higher up, whatever we have mentioned earlier. So the multiple cortical areas processes inputs from the trigeminocervical complex, leading to phenotypic expression of migraine pain and its associated symptoms. Here, the entire thing is being mediated by CGRP. Peripheral release of CGRP in the meninges, release of CGRP in the spinal trigeminal nucleus. So that's why CGRP is one good target for treating migraine. So these are the four phases we all know: prodromal phase, aura phase, headache phase, and postdromal phase. So prodromal phase, prodromal phase, aura phase, headache phase, and postdromal phase. So coming on to the available treatment options. For acute management of migraine, you can use acetaminophen, NSAIDs, combination analgesics, ergotamine preparations, migraine-specific preparations, melatonin, and antiemetics. So treatment options for prophylaxis available are beta blockers, anticonvulsants, tricyclic antidepressants, calcium channel modulators, and CGRP monoclonal antibodies like galacnizumab, fremanezumab, eptinezumab, or erinumab. So for prophylaxis, the European Headache Society has recommended CGRP monoclonal antibodies as first-line option for migraine prevention. So atogepant and remigepant for prevention. And the US FDA has approved botulinum toxin A for prophylaxis of migraine. So ultimately, it's the lifestyle modification that decides the treatment that that betters the patient. Avoid the triggers. Regular routine for hydration, eating, stress, and sleep are beneficial. Treat anxiety, depression, pain syndromes, fibromyalgia, and also sleep apnea if present. Now, let's go little bit deeper into what is botulinum toxin. As you all know, botulinum toxin is the most powerful poison, and what is that? From we get it from the Clostridium bacteria. It's proved to be one of the most versatile therapy in all of the medicine. In 1980, Ellen B. Scott, an ophthalmologist, has identified its therapeutic usage for blepharospasm. And Andrew Bridger from USA has started using it for spasmodic dysphonia. Excuse me. Ali et al. Have described its usage in migraine. In FDA, FDA has given its approval for aesthetic effects in 2002, which were actually recognized in 1989, but the FDA clearance was in 2002. And Botox in migraine, FDA approval has been happened in 2014. So botulinum neurotoxin approved as a safe, effective therapeutic option for several clinical conditions, including migraine. Common basis, how do we use Botox is for all conditions, it's the overactivity of the neurotransmitter or neuropeptide activity. Botox inhibits that. Clinical efficacy is localized, highly specific, and reversible disruption of exocytic mechanism within the neurons and temporary inhibition of release of neurotransmitters. Let's see how this happens. You get this botulinum neurotoxin from Clostridium botulinum, Clostridium barati, or Clostridium butyricum. You have 7 variants A, B, C, D, E, F, G of neurotoxin. Generally, we use A, Clostridium botulotoxin A. It's a 150 kilodalton protein and a heavy chain and a lighter chain. Together with a dichain, it's a dichain molecule held by a disulfide bond. And this 150 kilodalton protein is cleavaged into a dichain molecule, 150 kilodalton proteins held by a disulfide molecule by proteases. You can see here, the light chain have 2 terminals. One is the C terminal and the N terminal. The C terminal is for docking at the nerve ending, and the light chain acts as the entire light chain acts as a catalytic domain. See, botulinum neurotoxin A, you have a heavy chain and a light chain. These are held by a disulfide bond demarcated here in the red color. So this enters into the motor terminal, that's the nerve ending terminal, and being endocytosed. Once it goes into the nerve terminal, the heavy chain and the light chain are cleavaged, and that means the disulfide bond is cleavaged by the protease and the light chain is released. So what happens in the nerve terminal? The acetylcholine, which are present in the vesicles, are being brought to the end of the neuroreceptor through a protein called, and this vesicle, acetylcholine vesicles, molecule vesicles are being attached to the nerve terminal through synaptobrevin protein. Actually, the synaptobrevin protein goes and gets attached to SNAP25 and VAMP proteins here, the receptors. So now the target for this light chain of Botox toxin is to attack the SNAP protein, SNAP25 protein, VAMP protein, and synaptobrevin. It actually breaks the synaptobrevin molecule and also SNAP molecule, so that the acetylcholine vesicles will not get attached to the nerve ending, thereby does not get released from the nerve ending, which does not transmit the signal. So the target for the Botox is synaptobrevin as well as the SNAP25 and VAMP proteins. So this is what it happens. This is the synaptic vesicle consisting of acetylcholine, and there are 3 proteins that are to be acted: SNAP25, synaptobrevin, excuse me, and syntaxin. SNAP25 is being attacked by botox neurotoxin A, C, and E. VAM protein or synaptobravin is affected by Z, B, D, and F. And syntaxin is affected by C. Okay. Now let's get into how this Botox acts in migraine. Botox, botulinum neurotoxin A, or for that matter, any other, will smother the mechanical nociception in fringe TVC neuron. TVC is the trigeminal vascular complex neurons. So the trigeminal and the meningeal nociceptors are thought to have a noteworthy part in the onset of headache migraines. We have seen it earlier. And this neurotoxin A slows initiation of the headache by preventing high threshold mechanosensitive particle channels involved in mechanical pain from intertwining into the nerve terminal layer. That means from the dura mater to the efferent fibers, the transmission, the neurotransmission is being inhibited. That is, the acetylcholine is being inhibited. It also inhibits the CGRP. It has been shown already that it also inhibits CGRP. So now what are the indications to use Botox in migraine? Actually, the indications here for Botox in head and neck surgery and ENT and head and neck surgery, you can use for pathological conditions in ENT and also for aesthetic indications. I will leave these aesthetic indications to Dr. Vishwas. He is a master in that. So let's see about the pathological conditions. So you can use for any of the dystonias in head and neck area, any of the motor disorders, pain syndromes, and also autonomic disorders. So let's confine our talk for the pain syndromes where we use Botox, particularly migraine. But I will give a brief overview of the other disorders where you can use Botox in your regular clinical practice. In pain syndromes, you can use it in migraine, chronic tension headache, and also in trigeminal neuralgia, where the patient is not willing for microvascular decompression. So now the usage of Botox in chronic migraine. In which patient do you give Botox? So patient has already been on migraine prophylaxis, is not getting benefited. So the patient is having headache at least for 15 days in 1 month. And out of this, 8 days are classical migraine features. And this should continue at least for 6 months. So headache for 15 days in a month, out of which 50% are classical migraine attacks. And this should go for 50% of the year. That means more than 6 months. So apart from acetylcholine blockade, botulinum neurotoxin also inhibits substance P, glutamate, and CGRP. So you know what is Botox now? Where is the point of action? What does it inhibit? It inhibits acetylcholine release, substance P, glutamate, and CGRP. Now, when to go for Botox in chronic migraine? Again, the same thing. The 15 or more headache days in a month, at least 8 days are with classical migraine for 6 months. And the second indication is if the patient is having inadequate response or intolerance or contraindication to at least 3 prophylactic drugs. That is propranolol, amitriptyline, methotrexate, pizotifen, cyproheptadine, or topiramate. Yes, in these cases, even you can use CGRP antagonists or immunoglobulins. CGRP immunoglobulins are also very expensive, but you can opt for even Botox. The third indication is medication for use headache. The dosage and duration. So initially the treatment is paced for every 3 months. If the first 2 or 3 times, we'll give it for every 3 months. After 2 or 3 doses, that means almost like probably 6 to 9 months, there should be a significant reduction of symptoms. And the effect of Botox can last from 10 to 12 weeks to up to 10 months. I have patients who come now once in 9 to 10 months for Botox prophylaxis. Surprisingly, 3 people out of these, my entire patient portfolio were neurophysicians. So if the patient is not improving after first 3 doses, then discontinue the treatment and go for another alternative like CGRP, antagonists or immunoglobulins. So how do you get that? You get Botox in 50 unit or 100 unit vials. So I take 200 unit vials, dilute it with 2 ml of non-preserved saline, 0.9% non-preserved saline. I generally don't go for 4 ml, I go it for 2 ml in each 100 units. Okay. So I have now prepared for 200 units of Botox toxin in 4 ml total. 2 ml in one ampule and 2 ml in another ampule. So you can inject from 155 units to 195 units of Botox toxin. I generally follow for the past few years, I'm following this preempt criteria. Preempt criteria is the phase 3 research for evaluating migraine prophylaxis therapy. This criteria uses the usage of 195 units, maximum of 195 units. And we inject it in 31 to 37 sites in the entire head area. So just to make sure, if any one of you are having migraine, you must be noting that there will be severe pain here. What is this muscle? This is the procerus muscle. And also you will be having very severe headache on the medial aspect of the eyebrows. These are the corrugator supercilii. So you know here, you need to inject it into procerus, you need to inject it into corrugator supercilii. And also into the frontalis muscle and also into the temporalis muscle in the anterior aspect. Lower half of the face muscles generally don't need any injections in migraine. Now, on the lateral aspect, you need to inject it into the auricularis superior muscle and temporoparietalis muscle. Posteriorly into the occipital frontalis, occipital muscle, and superior semispinalis capitis muscles, and also into the trapezius. Now let's go through the individual spots. So now this is the procerus. This is where you need to give the procerus injection. And this is for the corrugator supercilii. Generally, I go for this like as described here, procerus and 2 injections in the corrugator supercilii. And in the frontalis muscle, I go little lateral to the mid-pupillary line. Little lateral to the mid-pupillary line, you inject 2 spots. So the first spot, the second and third spots on each side. That means by now you have given 5 injections here and 2 spots in the frontalis muscle on either side. That means 9 injections. Just you go on to the bone depth. Just gently lift the syringe. Insulin syringe, generally I use insulin BD syringe, and gently lift the syringe up. So this is how we inject for the procerus muscle. And this is how we go for the temporalis muscle. So procerus and the corrugator supercilii and the frontalis muscle. And in the temporalis muscle, I generally give 4 spots. What I do generally is from the superior margin of the pinna, I take 3 fingers. I mark it like 3 fingers, and from there I keep 3 fingers like this. So understood? 3 fingers up, just keep it like that as a landmark, and then keep your index finger as a fulcrum. Go through 3 fingers like this. Now inject it here into the bone depth. So 3 injections this side, 3 injections this side, 6 spots. Earlier it was 9 spots on the front half of the face. On the lateral aspect into the temporalis, now you have added 6. 9 plus 6 is 15 sites are completed. Then coming on to the parietal area. Again in the parietal area, posterior half of the pinna, take it as a landmark and go up and inject it 3 spots here on either side. Again, it accounts to 6 spots. It's like 21 spots till now. Now, going on to the back, 3 spots on the occipital muscle on right side and 3 spots on the left side. Make sure that you hold that occipital muscle bulk and then you inject it. So again, 6 spots. 21 spots till parietal and 6 spots here, it makes the 27. Now what I do is, then I catch hold of this neck muscle, the semispinalis capitis here, inject it 3 spots here, 3 plus 3. 33 spots. Or if the patient is not having severe neck pain, I might restrict for only 2 spots here. Right? That might account to 31 spots. Then go for the trapezius injections. 2 or 3, depending upon the need. 2 on this side, 2 on this side. 2 at semispinalis capitis, probably accounting to 8. 8 plus 27 earlier, it's 35 spots. Or again, you can increase 2 more spots here, 1 in semispinalis capitis and 1 more in trapezius, accounting to 37. So 35 to 37 spots. And if any leftover Botox is there, ask the patient which side is having more attacks. If he's having left side, inject that thing into the left side. So what are the side effects or the risk factors of the botulinum neurotoxin? Most common side effect is the neck pain. So there can be inappropriate injection can cause drooping of the eyelids, pain at the injection site, muscle pain and weakness, loss of facial movement can happen, skin rash, itching, and surprisingly upper respiratory tract infection can also happen. The serious side effects include breathing and swallowing problems and problems due to spread of Botox. So its safety during pregnancy and breastfeeding is unknown. So don't give it in pregnancy and breastfeeding patients. And it is approved for usage in patients above 18 years of age. So finally, if the patient is responding for botulinum neurotoxin for so long time, and all of a sudden in the last 2 doses, if the patient is not responding for botulinum neurotoxin, you need to check the antibodies for botulinum neurotoxin, and henceforth that patient, the Botox will not work for those patients. I have one neurophysician, she's my classmate actually, in fact, and and of late, she developed antibodies for the botulinum neurotoxin, and Botox is of no use for her now. So what are the other pain syndromes where you can use Botox? In trigeminal neuralgia. So in trigeminal neuralgia, this is the scenario if you open the CP angle. Most of the cases, I do microvascular decompression for the trigeminal neuralgia, and I place a small Teflon between the, you can see this is the trigeminal nerve, this is the superior cerebellar artery, and this is the dandy vein. The superior cerebellar artery is pushing the trigeminal nerves at its root entry zone. And we need to place a small spacer between the superior cerebellar artery and the trigeminal nerves so that the nerve is being not stretched up. So this is how we place a Teflon between those two things. So for trigeminal neuralgia, if the mandibular division is being affected, we give a grid method. We draw a grid at the most sensitive point and we inject the Botox there. Generally, I do it in a sitting posture. If you are not comfortable, probably you can go it with a patient in the supine posture. In the next module, probably if any other option or availability of time is there for me, probably I will directly demonstrate the injection of Botox in a migraine patient. It takes around 25 minutes. So Botox can also be used in other dystonias like blepharospasm, facial dystonias, Meigs syndrome, or cervical dystonias and spasmodic dysphonias. I will show you a case of hemifacial spasms. Of course, this patient ultimately came for microvascular decompression of the facial now. Now the patient is doing very good. But initially, we have given Botox for her. And you need to inject it into the orbicularis oculi part muscle. See, this is the patient. Severe hemifacial spasm. So we have injected the Botox, and this usually acts for around 6 to 9 months for these patients. And this is the patient after 3 weeks. Absolutely no spasm. So these are the patients whom you can deal with in OPD purpose. Apart from migraine, you need to tackle these patients in the OPD. This is one good subspecialty. Of course, I'm dealing now only with the pathological aspects, and even this Botox can be used for aesthetic aspect. That itself is another lecture. Botox in aesthetic aspects, fillers you can use. You can use other aesthetic techniques. Of course, the master is there, Dr. Vishwas. He'll be more authenticated to tell these things. And you can use in Botox in certain motor disorders also, like hemifacial spasm we have seen, palatal myoclonus, and temporomandibular disorders. My favorite thing is the TMJ syndrome. Every one of us will see at least 3 to 4 patients of TMJ syndrome in our OPD. All these patients, most of these patients, if the TMJ is due to myogenic in origin, give Botox into the muscles. Okay. Masseter and the temporalis. These patients will respond excellently. This is one perspective most of the ENT surgeons should look into. Also, Botox can be used in other autonomic disorders like Fraze syndrome, hyperhidrosis, and siluria. So to conclude, Botox have like excellent spread of usage in ENT and head and neck surgeries. So every ENT surgeon can perform this Botox, particularly if there is a patient with chronic migraine not fulfilling the above criteria, that is 15 attacks per month, out of which 50%, that is at least 8 attacks, should be migrainous attacks, and these attacks should last at least for 6 months. The duration is for 6 months, and the patient should not be responding for regular migraine prophylactic treatment. So the learning curve is very small for these basic procedures, and no expensive equipment is required. Only if you are dealing with spasmodic dysphonia, yes, the right way to do it is with using an electromyography or electroneurography. If you are dealing with spasmodic dysphonia cases or TMJ syndrome with pterygoid muscle injections, medial and lateral pterygoid muscle injections, yes, you need to use an electromyography. So with this, I will conclude the lecture on Botox in migraine and other indications in ENT. I once again sincerely thank Dr. Deepak Kaldipur sir and Dr. Vishwas for believing me. And like I have been practicing this thing, Botox in migraine and these things for almost all for 6 years. And the results are pretty good, pretty good. And I of course, we do Botox for other pathological conditions like TMJ syndrome, we give. And also for aesthetic conditions, we go along with fillers and all. So this is one subspecialty where most of the youngsters, particularly the female colleagues, can focus on. Because most of the people are nowadays focusing on aesthetics. So this is one area where people can focus. And I once again sincerely thank Deepak Kaldipur sir, Vishwas sir, and the entire team of Micro for giving me this opportunity. And I want to sincerely thank Mr. Bhaskar to bear my tantrums in recording this video. For I have been postponing this thing for almost for 2 weeks, and of course now it has been done. So thank you one and all again. Thank you, sir.